Hello, I am Dr. Keith Burke. I am a professor of behavioral sciences in the Alcohol and Other Drug Studies program at San Diego City College. The AODS program is a state-funded vocational job training program for students who are studying to be certified alcohol and drug counselors. The AODS classes at San Diego City College give you all the coursework necessary to sit for the exam. It's also college-level coursework, and it's transferable for students who are pursuing an associate's degree or a bachelor's degree. It can often be used as preparatory classes too for graduate level study. So today I am going to talk about record keeping in substance use treatment. So this lecture will serve as an introduction to record keeping in substance use treatment. It is definitely not comprehensive. Well, actually it is comprehensive, but it's more of a survey of the main key points about record keeping when working in a substance use treatment facility. There are certainly more details and nuances associated with record keeping and documentation, and anyone who is watching this lecture should be sure when in doubt to consult with a supervisor when you're actually working in a substance use or medical treatment program. All right, so let's talk about record keeping in substance use treatment. First, a quick definition of terms, just to clarify that we're all talking about the same thing. Record keeping can be differentiated from documentation. Documentation is considered to be the completion of documents or forms, whereas record keeping is the written record created when something's done and the event is recorded. However, for practical purposes, the two terms tend to be used interchangeably in the field of substance use treatment. In fact, most people would probably refer to this as documentation. Just for the purposes of this lecture and to be a little bit more accurate, I will be using the terms records and record keeping, but again, record keeping and documentation basically means the same exact thing. All right, the legal and ethical requirements for record keeping. Record keeping creates an accurate written, or typed nowadays, history that details all the important aspects of clinical care. It's important for numerous reasons. The record creates an archive to remember what transpired in sessions, including group sessions, individual sessions, intake assessments, basically all the clinical services. Record keeping allows us to compare records to track progress, see how a client has changed from the day they came into the treatment program to now 4 weeks later. Record keeping provides important information for other treating healthcare professionals, the others who are in our treatment facility, or in a parallel treatment model where the client's getting treatment from us and from other entities. The records enable us to communicate important information with those healthcare professionals. And importantly, record keeping protects the alcohol and drug counselor from charges of malpractice or negligence. Now, keeping records of clinical services is a basic legal and ethical requirement in healthcare. These are just some quotes about record keeping. Clinical record keeping is an integral component of good professional practice and the delivery of quality healthcare. Patient records are among the most basic of clinical tools, and they're involved in almost every consultation. They are there to give a clear and accurate picture of the care and the treatment of patients, and they're essential to ensure that an individual's assessed needs are met comprehensively and in good time. Now, record keeping is a legal requirement in California. So the Health and Safety Code 123100 states, quote, persons having responsibility for decisions respecting the healthcare of others, meaning both the treating clinicians and the patient themselves, should, in general, have access to information on the patient's condition and care. It is therefore the intent of the legislature in enacting this chapter to establish procedures for providing access to healthcare records or summaries of those records by patients and those persons having the responsibility for decisions respecting the healthcare of others. Now, that's a lot of legal gobbledygook here, but essentially what it's saying in the state law is that everyone who's involved in the decision-making regarding healthcare treatment needs to have access to the information, in other words, the records, about the treatment. Now, this includes all the treating healthcare providers themselves and the clients and the patients whose healthcare treatment we're providing to. But for the most part, records are usually mostly for the other healthcare providers, which includes the recorder, meaning you, the person that's doing the record keeping. Record keeping is also an ethical requirement in California. All three of the certifying organizations who register and certify drug and alcohol counselors include keeping a record of the client services as an ethical requirement. So all three of the certifying organizations have the exact same language here, where they all say that registered and certified alcohol and drug counselors shall comply with all federal and state laws and regulations that pertain to record keeping requirements and patient-client records access. There's a link to the ethical requirements. And the addiction counseling, Addiction Counseling Certification Board of California. Sorry, had a little mind fart there a second ago. So anyway, the ACC-BC Code of Ethics also adds an additional statement. Registered and certified alcohol and drug counselors must maintain appropriate records in a confidential manner for the purpose of treatment planning and case management. All right, so who are we writing these treatment records for anyway? There we go. Sorry, my PowerPoint froze for just a second. So the records are kept for whom? So the records of client services are written for multiple audiences. This is really important to remember when writing the records. You're not just writing an individual session progress note for yourself. You're actually writing this note for many other people. And when writing the notes, you should assume that everyone that I'm going to list is going to be reading the record, whether this is true or not. This is particularly true in terms of what you decide to put in and not put in the record. We'll talk more about that in just a second. So the first person that you're writing the records for is you, the counselor who provided the services. So the treatment records are going to serve as an archive or a reminder about what transpired, and it's going to provide you a means of assessing the client's progress in treatment. There's a quote here saying that the primary purposes of the patient's record is to enable the clinicians to communicate with themselves. So essentially the idea here is that you're talking to yourself over time. In busy treatment facilities, you might have caseloads of 20, or even in some of the crazy places, you might have a caseload of 30 people, and there's a lot going on. You're running groups and you're seeing clients and you're doing treatment and case management, you have intakes and insurance utilization reviews, and it's hard to remember what's going on. So you haven't seen this client for a week and they're about to meet with you, and you pull up the record and it'll serve to remind you, oh yeah, that's what we talked about. And the client was expected to go to a Codependency Anonymous meeting this week and come back and tell me how it went. So what you're doing is you're communicating with yourself through the record. You are also writing the records for other treatment providers. So the record and the transcript of what happened may be used or needed for other clinical treatment interventions or administrative services like insurance billing and things like that. Other people need to see what's going on. So here, there's a quote saying, good clinical record keeping should enable the continuity of care, and it should enhance communication between different healthcare professionals. You are also writing the treatment record for the funder. So the funder is the entity or the organization who is funding or paying for the substance use treatment. Most of the time, this is going to be somebody other than the client. There certainly are clients who pay for their own substance use treatment, but most of the time this is a public health insurance entity like Drug Medi-Cal or VA Healthcare, or a private healthcare insurance company like Blue Cross Blue Shield, or it's a grantor, or it's a health maintenance organization like Kaiser, but somebody's paying. And funders always want to see the written record of the clinical services before they're going to pay or reimburse for that. And many of these funders are going to look very closely at the contents of the documentation to determine eligibility for continued funding, meaning they want to see, is the client making progress, but not too much progress? Is there still medical necessity, but the client's making enough progress to allow them to continue to keep paying for the treatment? Funders are fun, topic for a different conversation. Now, here's a big one. We write treatment records for legal purposes. We write them for lawyers, judges, and for rulings. So in the event of a question about malpractice or negligence or an ethical complaint, which will typically go to the certifying organizations or the Department of Healthcare Services, your record keeping, your documentation is going to serve as the primary evidence used by the lawyers, the judges, and other legal administrators to determine if wrongdoing or a dereliction of duty has occurred. Now, here's some quotes about this. Also, records will be your best defense in the event of a malpractice or ethics complaint or other litigation. Should the clinician be challenged in a legal action, treatment records can serve to document that the clinician has assessed, diagnosed, and treated the client according to the standard of care. If the treatment record, the treatment record is the clinician's main defense if assessments or decisions are ever scrutinized. Now, these are academic documents, research documents about record keeping and substance use treatment, and they're all telling you the same thing. What you put down in the treatment record is going to be extremely important in the event of any kind of legal or ethical challenge. Now, failure to document clinical services is one of the most common charges in civil lawsuits for negligence and ethical board investigations, meaning if you failed to document a clinical service, that is going to get you in trouble. And note that anytime that you don't document and something like this comes up, they will use the lack of documentation as evidence of wrongdoing in a lawsuit or an investigation. You failed to meet the standard of care as an alcohol and drug counselor by failing to document. Courts and external review bodies view the absence of documentation in the record about an event as evidence that it never occurred, no matter what subsequent claims of the clinician. What that means there is that if you fail to document the service and then you are sued and you're standing in front of a judge or you're talking to a lawyer, or there's been an ethical complaint about you and you're talking to the ethical board and you say, no, I totally addressed that. I told the client this. The fact that there's no documentation will be used as evidence that never happened, in spite of how much you verbally insist that that was the case. Having no records is illegal and unprofessional, thus demonstrating poor care. And then the standard phrase you hear all the time, if you did not write it down, then it did not happen. So we need to make sure that we write it all down so that we've got a record. Now, we also write treatment records for auditors. So treatment records are regularly pulled by auditors. Auditors are examiners who look at or review the medical chart for various purposes. They may look at it for billing purposes. They may look at it in order to renew a certification or a license. They may audit in order, to respond to some sort of complaint. There's many, many reasons why auditors look at the records. And auditors are allowed to look at the records as per the federal confidentiality laws, 42 CFR Part 2, which is addressed in a different lecture. So auditors include funders. So public-private health insurance companies have auditors that want to see the records. Here again, typically for purposes of payment. But it also includes state regulatory agencies. So like the Department of Healthcare Services, CARF, which is the Commission on Accreditation of Rehabilitation Facilities. JCAHO is another one of these accrediting bodies. So these are regulatory agencies that are going to pull records, again, usually typically to address certification and licensing purposes. And finally, we write records for the client themselves. This is very important to recognize that both federal law and California law give clients the right to inspect and copy their treatment records for any purpose. You cannot legally deny a client the right to look at their own treatment records, which you want to keep in mind when you are writing treatment records. Now, ultimately, the writing of treatment records, which I don't talk about in great detail in this lecture, but meaning the content, what you include and what you don't include, that's something that you are going to develop a skill with as you work in the field. There's lots of trainings on this. Certainly you want to talk to your supervisor, but it can be very helpful just to keep in mind, hey, if my client ever read this, how would my client respond? If my client ever read this, how would this affect the clinical relationship? And so typically you're going to want to be careful about the wording that you're using while still maintaining good, objective clinical content and including your assessments. So again, the rule of thumb, assume that your client's going to read whatever you're writing. Keep that in mind in terms of how you write it. Okay, so what do we include in the treatment record? There is currently, as of 2021, no state law that dictates or mandates the specific content of the treatment records. None of the ethical boards say anything about that either, nor are there any federal laws regarding what you must put in the treatment records. There's also no gold standard or definitive agreement about what goes into the treatment records. There are certainly a lot of books and articles out there about what to include in treatment records. Different organizations, treatment agencies have their own opinion about what should be included in the medical record. There's a lot of people that have an opinion, but ultimately the answer is you err on the side of including everything that might be important. So if you, another clinician, a lawyer, an auditor, the ethics board, if anybody was looking for something that should be in the treatment record, you want to make sure that it's in there. So better to have a bunch of superfluous things that wasn't necessarily really important to include in there than not include the things that are important. Now, by convention, so convention means standard practice, so not necessarily written down as a you must, but this is typically what most treatment agencies are going to include. These types of things are in the treatment record. So intake forms, intake assessments and summaries, integrated treatment summaries, things like that, integrated assessment summaries are included. A psychosocial assessment or history. This is getting detail about the client, their family history, where they grew up, was there substance use in their family, things like that. Supplementary or specialty evaluations and assessments. So like, for example, most substance use treatment facilities use the Addiction Severity Index or the ASI as part of their intake. So if you're working at an agency that uses the ASI, you're going to include that. Including current diagnoses, the diagnosis that you and your treatment agency have assessed this client as having, and also reported or confirmed previous diagnoses. So that, like, if a client comes in and says, yeah, I have a diagnosis of bipolar disorder, so who gave you that diagnosis? Well, my psychiatrist at my last treatment facility. That should be in the treatment record. A confirmed previous diagnosis means that you've gotten a copy of a medical record from the person that gave that diagnosis. You will include the treatment plan along with its goals and objectives. You will include all session progress notes. That includes individual session notes, group session notes, family counseling session notes, sessions with the psychiatrist, etc. The termination or the discharge summary should be included. The financial records of what's been paid for the treatment, what's owed for the treatment. That's not necessarily something that the clinicians are overly concerned about, but you can sure bet that your billers and funders are concerned about that. And then all legal documents. So informed consent documents, release of information, things like that should be included in the treatment record. And then you want to remember to include all correspondence with collateral contacts. So a collateral contact is someone who's knowledgeable about the client's situation and serves to support or corroborate information. So this could be a previous clinician, like reaching out, getting a release of information and having a phone conversation with the client's previous clinician or case manager, a family member, a probation officer, even sometimes other clients. So if another client came to you and said, I'm really worried about Alice, she looks really skinny. She passed out the other day. I haven't seen her eat anything. I think she might have an eating disorder. And you use that information to follow up with Alice, well, then you need to document that you had a conversation with that client about this. You're not going to include silly gossip about things, right? But important clinical information. All right, when does the record need to be completed? The simple answer to that is that you need to create a record as soon as possible after the clinical service is administered, or no more than 24 to 48 hours. So best practice is you write the documentation, or you do write the record keeping documentation immediately after your session. So the standard individual session out there in the field is 45 to 50 minutes to meet individually with the client, and then 10 to 15 minutes to complete the record keeping of that session immediately afterwards. So like if you were seeing 3 clients in a row at 1 p.m., 2 p.m., and 3 p.m., you see the first client from 1 to 1:45, and then you write the case note from 1:45 to 2. You see the next client from 2 to 2:45, write the note from 2:45 to 3. Third client at 3 to 3:45, write the note from 3:45 to 4. That's best practice. But again, as soon as possible. So if you're not able to do it immediately afterwards, you do it as soon as possible. And if you cannot finish it in the same day, then you should finish that 24 to 48 hours later. Now, usually leeway is given if the clinical service was on Friday afternoon and it's recorded on a Monday morning. So if it's Friday afternoon, Saturday afternoon would be 24 hours, Sunday afternoon would be 48 hours, Monday morning, now we're moving towards 50, 60 hours. So that's not 24 to 48 hours, but it's 24 to 48 hours in business days typically. Now, this is both practical and for the purposes of protecting legal liability. So the practical dimension of this is that it's really hard to remember what the pertinent details are of what transpired if you wait too long to record it. Using the example that I just said, if you're seeing 3 clients in a row at 2, 3, and 4 p.m., well, trying to remember who said what, especially if you also did a group earlier that day, and now it's the next day, and you saw another client, you ran another group, it's all going to get jumbled up in your head. And so that's why you want to write the record as soon as possible to make sure that you're recording it accurately. The other issue is for legal liability. So if a client or a patient claims negligence or wrongdoing and is able to establish that claim before the record was written, then it looks bad in the eyes of the court and the ethical boards, like you wrote the record in response to the complaint. So let's say that the client complains about you to an ethics board, or the client talks to their lawyer about you and insists that you did something inappropriate. I don't know, you self-disclose something inappropriate and ask the clients to come to your son's bar mitzvah, something like that. So if you wrote your record immediately after seeing the client, so you saw the client from 1 to 1:45, you wrote your note from 1:45 to 2, and it's there. And then the client complains to the ethics board or the lawyer, well, they're going to pull your documentation. They're definitely going to want to look at the audit. But if they can see that immediately after the session, you wrote the note looks good, it looks comprehensive, you did an assessment, there's nothing in there about your son's bar mitzvah, 9 times out of 10, they're going to give you the benefit of the doubt that you did the standard of care. But let's say that you didn't write a note, and then they complain to the ethics board. And then the ethics board lets you know that they were investigating the complaint. And now 6 days later, you go in and write a note. That doesn't look very good, right? The complaint was already voiced, and now you're writing the note. It looks like you might be writing the note in response to the complaint. Of even greater legal liability, and unfortunately this happens in the field that we work with, if a clinical service happens and then the client dies, from a drug overdose or they die from completing suicide before the treatment record is written for that service and the clinician sued for negligence, this looks very bad in the eyes of those who are judging potential wrongdoing. It may look as if you wrote to protect yourself. So the best way to take care of this is write your notes as soon as possible while you remember what happened in good clinical practice. It's also worth noting that failing to keep records or not completing your notes in a timely fashion is one of the top reasons why alcohol and drug counselors lose their jobs. So the bottom line is that treatment records need to be written as soon as possible. And if that's challenging for you, then you need to work on your administrative and organizational skills if necessary. Please don't get fired. All right. And then finally, how long do records need to be kept? So there actually is a law about this in California. Per state law, medical and treatment records must be preserved for a minimum of 7 years from when a client is discharged. So if they are discharged on November 15th, 2020, then November 15th, 2027 would be the first time that you could discharge or get rid of the records. But nowadays in practice, most substance use treatment records are electronic and they don't take up any space. So treatment records may be stored for an infinite amount of time. Your medical record may end up being forever. So this used to be a bigger deal when it was paper files because the paper files would take up a lot of space. When I first started working in the field, we didn't have electronic records, we had paper records. And this was something that I did as an intern. Where a bunch of interns would get together and each month we would go down and we'd open up a file and we'd shred all the records from 7 years from that date, because where I was working at the time didn't have a lot of space and we had a whole lot of records. But again, it doesn't take any space in a medical record once it's electronic, and those records last forever. All right, so again, this was an introductory survey of record keeping and substance use treatment. This can start to get really complicated when there's multiple people that are treating, and who's putting in what and what needs to be accounted for, and do we have the releases in place? And so when in doubt, you want to make sure that you seek supervision. All right, that brings us to the end of our lecture on record keeping in substance use treatment. For those of you who are watching this video as part of a course at San Diego City College that you're receiving credit for, this is the keyword or key phrase non sequitur. So you're going to be tested upon the conclusion of this video, and one of the questions will ask for the keyword or the key phrase. Now, this keyword or key phrase will not be on the PowerPoint slides, and the student's only going to know it if they actually watch the video. So the key phrase for this video is records are not just for a turntable. Again, records are not just for a turntable. All right, so I dropped that key phrase in various places in a lecture. This is the first time I've done it at the end of the lecture. So this will reward those of you who watched all the way through until the bitter end. Okay, if you are watching this lecture on YouTube, you are more than welcome to comment on this lecture. If you have any questions, I'll be happy to follow up with you. And if you're watching this as a student in the AODS program at City College, presumably you have my email and/or access to me in the class. And so if you have any questions, please follow up with me there and then. All right, thanks for listening.